morning. I want to TB find all TB, treat all TB, prevent all TB, end TB. Vital strategies, Asia Pacific Cities Alliance for Health and Development, Asia Pacific Media Alliance for Health and Development, and CNS. I welcome you to this session on community leadership, driving the call to find all TB, treat all TB, prevent all TB, to end TB. Initiative in high TB burden countries. We are grateful to the Union for giving us this space in the conference. And we are also grateful to Stop TB Partnership, Humana People to People India, and Dr. Dirgh Singh Bam for their guidance and also for the support to help some of the panelists to be here today in person. Finances are always a big problem for many of us to attend a conference on site. Community-led, people-centered, human rights-based, and gender-transformative interventions to find all TB, treat all TB, and prevent all TB are critical if we are to move towards ending TB. Let us hear more from our speakers today. Without any further ado, I would like to invite Dr. Dirgh Singh Bam to deliver the opening keynote address. Dr. Bam is a renowned chest physician and former Health Secretary, Ministry of Health and Population, Government of Nepal. He is former Director of National TB Program of Nepal too. Welcome, Doctor.
Thank you very much, our chairperson and co-chair Tariro Kutadza, speakers, distinguished delegates, community leaders, and fellow advocates. This is the priority in our life. We are telling too much about tuberculosis, but in the context of practical approach, this is very small. Now you are realize how we are going to recognize this TB control program in each country, right? So it is an honor to be here today among such dedicated advocates, researchers, policymakers, program managers, health workers, and community leaders, all of whom are united by a powerful vision. What is that? A world without tuberculosis. We don't like to live with tuberculosis disease. TB a concern of all of us and each segment of our community, from policymaker up to public individual sufferer from tuberculosis disease. We know TB is a disease that, despite being curable, continues to claim over 1 million lives each year and affects millions more. In communities around the world, TB has deeply rooted itself as both a health crisis, social burden, economical burden also. Today, we gather to commit ourselves to a moment that connects and empower communities to eliminate, eradicate tuberculosis disease every sector such as executives, legislator, private practitioner, media, mothers group, female health volunteers, teachers, researchers, and people affected by tuberculosis must be engaged and motivated to act accordingly. By building a supporting these communities, we create sustainable strength needed to find and treat every case of TB. Together, we are forging a path toward a free future grounded community power and collective responsibility. Community leadership, a force of change. Community leaders trusted and aware of local needs drive impactful changes against tuberculosis. In Nepal, a coalition of diverse voices, media, mothers group, female group, TB survivors, youth, pharmacists, health workers, volunteers, farmers, and civil society unite to make TB services accessible and life-saving. These leaders foster unity, raise awareness, and create safe space, inspiring individuals to seek testing and treatment as symbol of hope. They are essential in mobilizing communities and strengthening the fight against tuberculosis. Find all TB, treat all TB. The role of community in TB detection. To detect all TB cases, grassroots approach is essential, involving home visits and understanding local, social, and cultural context. Communities are key to this, as shown in Nepal, while implementing directly observed treatment supports. We created trust committee, which involves all the people who are residing in the civil society. This approach reduces stigma and barriers to access. Local leaders connect the people to resource, dispel myths, and emphasize TB is treatability, while outreach workers reach remote areas, ensuring no one is left behind in the fight against tuberculosis. Treat all TB, empowering communities in treatment support. Detecting TB, this is the just starting, beginning. Successful treatment demands patience, consistency, and robust support system. Community leaders are essential in promoting treatment adherence, peer support, and personalized care. In Nepal, partnership with private practitioners, health volunteers, youth, and community members foster health education, reduces stigma, and support adherence. Treatment outcome improved when trusted individuals who understand patients' personal and cultural changes and there to guide and encourage them on their pathway to recovery. Building power community as a catalyst for policy and resources. Building a community power extends beyond the individual's empowerment. It unites voices to drive demand for resources, policies, and sustainable solution in Nepal, strong political commitment across the executive, legislative, and judicial has been secured, but it must be sustained and expanded to ensure accessible health care, affordable medication, and accountability in the community leadership also enables partnership with the local, national, and global stakeholders. With the right knowledge and the tools, communities can hold governments accountable, direct resource effectively, and promote investment to make find all TB, treat all TB a reality for all. A call to action. Now we have to go action. We are at a crucial moment in the history. Already after the discovery of Mycobacterium tuberculosis, we spent 142 years. Nowadays, we have the effective medicines, very nice knowledge to control the tuberculosis disease. Why we are failing? Every year giving the new slogans to eradicate, to eliminate tuberculosis disease in our society. Community free TB path of TB free would be not easy, but by building strong community leadership, we have already paved the way to change. Together, we have the power to find all TB, treat all TB. Let us make a call to action to every one of us to strengthen and the leadership for screening, early diagnosis, early treatment, breaking the chain for transmission to in tuberculosis. Then we can prevent all the society who are residing in the community. So this is my feeling after having the long time cases. Here you can see here female health workers and minister is giving the directly observed treatment such course. Traditional healers are here, and most of the time in the Nepal, female health volunteers are the key person to hold the cases, to treat the cases, and to find the cases, and even in the jail, prison, we use the priest or in masjid or in mandir or in church when they will deliver the speech for tuberculosis control program. We should not live with TB. That was the approach in Nepal, and we succeed. Very nice result in the world. Thank you very much.
Why was the call? Can you hear me? Launched. I'm reminded here of the opening of this Bali conference when Dr. Guy Marks, President of the Union, said, "It is time to stop decades of failures. We have a lot to do to end TB." We never ever have been on track to end TB historically, in high burden countries at least. At best, we have been diagnosing and treating TB and saving lives and preventing some TB, but majorly failing to end. If we could prevent TB, then how come 10.5 million people got infected with the disease last year, as per WHO Global TB report? It is like failing 10.6 million times in preventing TB. Of course, over the decades, a lot of work has been done to control TB, but we have not been in the TB elimination mode. Unless we find all TB, we cannot stop the spread of TB. And then, finding all TB is not enough. Finding all TB early enough, and mark the words, early enough, is critically important if we are to end TB. If we can find TB early enough, when it is asymptomatic, and link each of the persons to proper effective TB treatment and support them through the treatment and care, we can help shift the gears from TB control mode to TB elimination mode. Finding all TB early and accurately needs the program to be rooted in elimination mode. And we have the need to change TB control program to TB elimination program. WHO gave the find, treat, all call in 2018 for governments to replace the underperforming microscopy test with those with 100% upfront molecular testing by 2027. Yet, in the year 2023, less than 50% of those with TB who could get diagnosed were diagnosed on microscopy globally. Microscopy, as we all know, misses half or more of TB. So we miss the other half of people who had TB and they took a TB test. We miss them because we used a bad test. Most importantly, we have WHO recommended only point of care, battery operated, lab independent molecular test through NAT. And I'm sure Samantha will talk of her experience about the use of that. That also runs on solar energy. And we have ultra portable handheld X-rays backed with computer aided diagnosis, which can help screen asymptomatic people with TB early on. Why are we not deploying these tests on scale? Till we get a safe and effective TB vaccine and roll it out quickly with equity and justice once it is there, let us at least roll out the best of the currently existing TB tools that are available for diagnostics, treatments, and TB prevention. We have to do all what science and evidence shows works to prevent TB and stop the spread of infection. Keeping this in mind, over a year ago, many individuals and organizations came together to launch the global call to find all TB, and also to stop the spread of infection and reduce human suffering. TB People India, Asia Pacific Cities Alliance for Health and Development were among those organizations that led the process with support from Municipal. Thanks to the union also, which has endorsed the call to find all TB to end TB. And in November last year, at the Union World Conference on Lung Health in Paris, the opening ceremony and closing official press conference both had strong echoes of the call to find all TB, thanks to Dr. Dirgh Singh Bam and Dr. Guy Marks for amplifying the call. Later in December 2023, TB People Zimbabwe, under the leadership of firebrand TB and HIV activist Tariro Kutadza, is here with me today. Africa launch of the call to find all TB and HIV took place at Africa's largest AIDS and STIs conference, APCAT, in Harare, Zimbabwe. Towards the end of January 2024, at India's National Conference of TB and Chest Diseases, NatCon, which was held in Thrissur, Kerala, journalists came together to host a media workshop on finding all TB. At NatCon, 149 TB experts endorsed the call to find all TB, treat all TB, prevent all TB if we are to end TB. Then again, in February 2024, the 16th session of World Social Forum that was held in Nepal under the theme of Another World Now, there was one session on finding all TB and why it is too critical for achieving the SDGs. It was hosted in the Ministry of Health and Population, Government of Nepal, by Health GB Online Nepal and partners. Before World TB Day 2024, the annual online NTB Dialogue Summit was held on the theme of Treatment is Prevention, Find All TB, Treat All TB, Prevent All TB. Over 1,000 participants attended the sessions that were spread over 7 hours. In May 2024, NTB leaders from 34 high-burden countries, mostly Asia and Africa, including ministries of health, came together with support of TB People Zimbabwe, TB People India, and partners in Molbio, and put forward the Goa Declaration. The Goa Declaration was formally launched with hundreds of endorsements from a diverse set of stakeholders in an official affiliated event of AIDS 2024, the world's largest AIDS conference, on 4th of July. Almost 40 TB and HIV community and other organizations, including government agencies, formally endorsed the call to find all TB. Today, we have over 2,000 organizational and individual endorsements of the call to find all TB. But unless it translates into concrete action on the ground, we will not be able to end TB. TB programs will have to screen everyone and not just those with TB symptoms, with WHO recommended screening teams. Confirm those with presumptive TB using molecular tests, put them on appropriate treatment, and ensure that they complete the treatment in a socially just and equitable manner. Thank you for your attention. I would now request Tariro Kutadza, leader of TB People Zimbabwe and coordinator of Africa Call to Find All TB, a member of Union Community Advisory Panel, to share more about Africa launch of Call to Find All TB and the experiences and learnings and the way forward. Thank you.
Okay, thank you so much. Thank you, everyone. I think our journey after launching treat OTB, prevent OTB, and diagnose OTB was done through an advocacy. It was launched global, but East Africa also launched it. And our journey is showing us that if we launch something, we can do follow-ups regardless of our distances, regardless of where we are coming from. So I'll start my presentation by quoting our own chairman, came up. He said, if you don't want to treat them, don't find them. Because, don't find them. If you don't want to treat them, don't find them. And we are only 71 months left to LTB. When we put them in years, it's like it's a very, very long time. So I always want to express this journey through months. 71 months to end pandemics. Are we ready? So the overview will find all its all prevent all initiative launched at APCAT in Zimbabwe, Africa. So it was launched on December 8, 2023 in Harare. And this initiative aims to address the intertwined challenges and HIV and AIDS across Africa. We are so working in silos. The person living with HIV and AIDS does not come. but tuberculosis close. But even the people doing the HIV/AIDS, they don't understand that tuberculosis is key. Not only that, even our NTPs, even our minister, they are so working in silos. HIV on this one, TB on this one, but we are dealing with the same person. And what we should address is that thing that kills someone, which is TB. So what were the key aspects of the initiatives? The key aspect of this campaign was to look at comprehensive approach. How can we have a holistic strategy that tackles TB and HIV as an entity, and also to recognize the overlap between affected populations and health systems. Number two, community engagement is very key. Not only emphasizes on community responses, but also looking beyond the volunteers. What's the role of volunteers? The interface of the clinics, the healthcare centers on the ground. But at most, they are nowhere. I was challenging even our chair to say, where are the nurses in this conference? Where are the volunteers with this conference? Because the nurses is the interface with the community. They live with the community. They are the first port of call, but we leave them in platforms like this one. So this campaign also looks at community engagement, and also it looks at the key thing on funding and resources. The buzzword these days from any donor is they are talking of pushing away from our countries. They are talking about transitioning. They are talking about sustainability. So if you are transitioning, you are moving away, and you are saying sustainability, how are we going to sustain the gains we made in TB and HIV/AIDS? So domestic financing becomes very key in this campaign as a strategy. Also, we looked at global collaboration, which needs to foster partnership among stakeholders, including governments, NGO, private sector, which is our key partner. But in most cases, we tend to overlook the private sector. But they're the ones we are coming up with this initiative of diagnostic tools, all this private sector. But on some tables, push them away. We push them away, and we speak about their work when they are absent. But this campaign puts everyone on the table. So what was the context of launching this campaign on APCAT? So it served as a pivotal platform for discussion, for discussing innovative solutions for ending AIDS by 2030 and addressing the TB agenda. Those who know ICASA, International AIDS and STI in Africa, they have never allowed anything about TB. So this was the first time ICASA had community sessions for TB. And we really applause Shoba, Olympio, and all other partners for helping us come up with a concept note and see to it that TB was also in the big agenda on ICASA, including people being screened, TB, diabetes during that time. And we really applaud for this initiative. And also, there was a lot of reflection on community engagement during that ICASA, including community workers. We had sessions by community health workers because they are there. They are at the center of this pandemic, and they are the first to meet our people affected by diseases. Okay. Then, what did we do to date? Yeah, most times we launch things. The next conference we launch another thing. The next conference we launch another thing, but we don't follow. Only launch. As that helped us to end TB. So we launched December 23, and as a follow-up, Also, what did we do? Yes, we alluded, we did a lot of webinars. And the most difficult one for me was the 7-hour ones. Because it's like we are coming from different regions. So I started 3 a.m. up to 2 p.m. in my country. I was like, this dozing. But I was dozing, but I have to be there because it attracted all sectors and I learned a lot. And I'm not even done with the knowledge I got and the gaps I got for TB because of those webinars. And also, one of the things that come out from this campaign is private partnership development. I didn't know it's so easy to partner with the private sector because they've got a lot to do. But if you just go say, oh, one money for what? They're profit making. But if we are also talking their language, trying to understand their work, it's very easy. So it gives us some partnerships, strengthened collaborations among governments, NGO, and community organizations and health providers. And also, it fosters strategic partnership in going to respond to TB diagnosis. We didn't have the language. We did not have the language about diagnosis. And I'm in the CCM, people talking of procurement, diagnosis of like, then they say, any objection, you can't object. You only object on things you don't know. But now, to tell the truth, I am so empowered. I can link my advocates with the science. I know the difference between molecular and all the difference between XRP and so on. So we also had a learning visits to India, which attracted 31 countries, and we really thank our partner Municipal for doing that. So in conclusion, the takeaways from the campaign, as we continue to do this campaign, is to call for increasing domestic financing. Number one. Number two, we should also focus on youth engagement. And the number three, multi-sectorial partnership. And lastly, we need to enhance HIV/TB collaborative activity and run away from the silos. I thank you.
As we are running short of time and the community will be thrown out of this room at 10 o'clock. So please take just 3 minutes for your presentation.
Oh my God.
Small is always beautiful. Now I invite Dr. Samantha Tinsay, Municipal Health Officer, Bantayan Municipality, Cebu, Philippines.
Good morning, everyone. I don't want to get kicked out of the room. Good morning. I'm Sam from Bantayan Island. This is Bantayan Island. It's an island in the northernmost part of Cebu, smack dab in the middle of the Philippines. If you've never been, you should because it's beautiful. That's why I fell in love with the place. Not only that, but we also deal with logistical challenges also. So pump boats are our main form of transportation. As you can see, we don't just have one island, we have multiple islands, and I've been to all of them. And this is what happens when it's low tide. You don't believe in climate change? Look at this. When it's low tide, you have to take special smaller boats to get to the bigger boat or to get to the other side of the island. So logistically, it's already difficult. We are called GIDA, or geographically isolated and disadvantaged area. So sometimes you also have to look for high tide in the middle of the night. This was one of my medical officer's first days of work. We had to wake up at 12 midnight to deliver health services to another island. So sometimes you have to be you can adjust. So this was the first INTP project in Bantayan Island in September 2022. This was with USAID and FHN 360. We dealt with the 3 tools, the TrueNAP, the CAT4TB, and also the ultra portable X-ray. I just wanted to highlight this. As you can see, we went from very, very bad case finding during the pandemic. And even before that, we did horribly. I wasn't working there yet. But in 2022, we jumped up. And as you can see here in 2024, because we had the tools for way longer, you can screen more people so you can find all TB. Okay, so this is our algorithm. We can discuss it another time. And this is our cases. As you can see, having the tools available can actually increase your case detection and case notification. As you can see, previously, we were so bad, 39-40% case detection, and then now in the 90s, and this year, even 99%. So we've also bundled health services. So we don't just focus on TB. When we go out in the islands, we also focus on primary care, delivering all the services to the people. We have dental, laboratory, medical, psychiatric, psychological care as well, because mental health is also important. And we also give directly on the spot treatment. So when you get diagnosed with TB on that day, you get treatment on the spot. You even get an HIV test and a hepatitis test the same day, because we believe that patients should be able to have access to services, and so that they don't have to go around, because money is actually an issue in the island. We also leverage technology. This is us putting up a Starlink in the middle of a basketball court in an island, hundreds of miles away. We're doing this because we also have to be resilient, be sustainable. We also get money from PhilHealth or social health insurance to fund all our health programs. So this is in addition to our local budget. So again, searching for high tide, this is us walking around the island with thousands of dollars of equipment. Good thing we made it, but we almost didn't. So when you're searching for high tide, we got caught in the middle of a storm. There's actually a typhoon coming right now to the Philippines. So this, we're still smiling here, but then 3 hours later, we almost didn't make it to the other side. They had to deploy the Philippine Coast Guard to pick us up. Anyway, let's go back to TB case notification. As you can see, having these services, having technology accessible, really improves case notification. In the Philippines, the baseline is 379 per 100,000. But as you can see with the tools, we were able to do better. In 2023, it's a little bit lower because we only had the AI, the ultra portable from November to December, because DOH had to use it in other locations. Okay, but in 2024, we had it for about 7 months. Okay, and in 2022, because COVID during the pandemic, you're gonna have more cases because everyone was stuck in their house. Okay, so again, we're bringing health services to geographically isolated populations, and I dedicate this presentation to my medtech, si Ma'am Lalaine. She actually didn't make it. She passed away a few months after this project. She passed away from liver cancer, but she was instrumental in getting this program started. We have to remember the people. And again, we bring health services not only to those who can access them, we also give them to disenfranchised populations, such as those in the jails. We also do home services and home care. I visit patients in their homes. We have a rotating schedule, because sometimes people who are bedridden, disabled, senior citizens, they cannot have the proper access to care. So that's why we go to them instead of them coming to us. So again, for TB treatment success rate, because we also utilize our community health workers and we incentivize them, we don't have an issue with treatment adherence. Again, we need political will and political commitment in order to have these health services available to the people. So I work with the local politicians to get ordinances and laws passed in our community. So hi Tom, you're here. So we also work with WHO and other partners to make sure that we have these services available to the people. That's our mayor and his wife and then me. And then this again is just empowering the community. This is my last slide. This is the most important slide for me. This is Joseph, my patient with POTS disease or TB of the bone. He was left to die. This was 2 years ago, and this is him now. We have to remember, when we do TB work, we're not doing this because of money, accomplishments, because we're gonna get a raise. We do this because of our patients like Joseph. I do this work. I didn't become a doctor to get rich or anything like that. I became a doctor to help. And you should remember that as well. Thank you. If you want to get my information, you can scan the QR code and check my email there. Thank you.
People like Samantha. Each one of us should do what we can. I now invite Dr. Kuldeep Singh Bam, former head of Indian Congress National Studies Program and National AIDS Program, former Southeast Asia Director of the Union, and President CMO of World Biodiagnostics. And I would request once again the speakers to keep small is beautiful.
I'll keep it as small. So I'm not referring to the burden of TB disease. We all know. Means that we still have a long way to go. The challenges of high burden settings have been difficult to reach areas, travel, disadvantages, population, so geographical disadvantage, patients are marginalized, poor, etc. So those are the challenges of urban area, in addition to being overcrowded and a lot of transmission going on there and delayed diagnosis. But thankfully now, for find all, treat all, prevent all, we all have tools for that. Even for disadvantaged areas and difficult to reach areas, we have diagnostics which are referred to as point of care by battery operator, which can reach the most difficult to reach areas. You have drugs which can cure 100% of patients. Now you have a drug to offer preventive therapy. You have airborne infection control. So far as tools are concerned, we are all in position to tackle those things. In addition, now we can also screen the entire population with so-called handheld X-rays, the cuff sounds powered with artificial intelligence. So there are enough tools which can help us to get there. And really, I mean, at one time, HIV raised slogan of 1990, and we were wondering why not 100 and 100 and to WHO and the call for action which is that we actually are aiming for. So that's the way it should go. So I have few examples of screening in hybrid settings. The brilliant example, Samantha, with all pictures has given that. So there are, this is Philippines example, so I'm not going to read it. Thanks. You know, I can skip one slide very quickly. This shows in 6 countries where point of care that was introduced, and you see that in those disadvantaged populations and difficult to reach areas, we have seen an increase of about 57% case detection. So in particular geographies where you can't reach, you do see a huge increase in case detection. Thank you. So that's the beauty of having new tools, which is point of care tools which you can carry anywhere. They're battery operated, you are not dependent on electricity. You have screening devices, handheld X-rays, battery operated, you are not dependent. And you see, she demonstrated almost from 25% to 99%, and we here demonstrate almost 60% increase in case notification in such a similar examples in Nigeria, and what the take-home message is that practically you can also screen about 100 patients a day with your handheld X-rays and screen them. So when you plan for find all, you have to plan accordingly that what is the maximum workload one will find out in a practical circumstance. People will say they can screen 200, 300, 400, but practically when you consider the areas where you are using them, that's target around 100 cases there. I have already referred to what we handled X-rays. Okay, one example, they said that if you have to find all TB, also look for TB in not so vulnerable population. That is where you will find all TB. So 50% of TB you can find in vulnerable population, but 50% of TB you will find not in people who don't have regular symptoms. So this is an example when you screen university students for a common health checkup. You also find TB in that. And that has also been demonstrated in various regular surveys, which shows that almost 50 to 60% of individuals who test positive TB will not have any symptoms. That is catching them early. They will have symptoms 6 months or a year later when the disease gets very advanced in the hospital. So it's not that you will miss them, you will catch them after a year. But that's not the aim of eliminating TB. Aim of having TB is to find them as early as possible, and then new tools help you to find even when they are not symptomatic, they are not showing any symptoms, they look healthy. So you can find 50% of TB in healthy population. The message is that you can find 50% of estimated TB in healthy population if you reach them through your tools of screening, whether you use handle X-ray, whether you use cough sounds, whether you use sputum examination. The tool is up to you to choose in your own settings, but you have tools to find those patients which you cannot otherwise find. So reach out to, try to reach out to the entire population as far as feasible. Look at your resources or give example. So the one example, if you see the latest TB report 2024, they say the global decline in incidence is about 8.3%. And when I look at decline in my country, it is about 17%, which is double. So it's not that they have screened the entire population, but they have started to introduce active case finding in their routine. So every Saturday or Sunday, and holidays, just one simple intervention. This it helps. I see the Shobha getting up. Why not? Treatment, I've already alluded, hugely effective drugs you can cure. Preventively expect a vaccine. Yes, but short of vaccine, you have preventive therapy, you have one infection, awareness. So, these we reach to community as we say, innovation. Call to action, call to action.
And now we have Dr. Dirgh Singh Bam, Board Director, Asia Pacific Cities Alliance for Health and Development, Asia Pacific Director, Tobacco Control, Vital Strategies and for Asia Pacific.
I think I'm not going to have 3 minutes. I put a significant amount of time to prepare my slides. Why? Because I would like to present the same slide in coming conference, maybe an upcoming conference next day or maybe next day. Why? This is my one of the big question to all of you. How many of you would like to see the same slides when I present next year conference? I think I'm done. So you all are here to make a difference. We don't want to see the same statistic over and over and over. So then I have to prepare again. Sorry. So I think one of the key things why you can look at this one. So I have this couple of slides I spoke this morning also on this topic, smoking and the tuberculosis. I think that is something we need to also pay attention. We have very good diagnostic tools. We have the treatments. We have the support from the different communities. But what we are not doing in our TB control program to really address the risk factor of TB. That is something we need to really pay attention. So, I have several slides that I would like to contribute this slide as well. So, the WHO is a global community hospital against 5 key risk factors. Smoking is one of the leading factors. So, I don't know how many of you attended any of the sessions in this conference who really talk about smoking and TB. I don't know. When the physicians, when the medical doctors, when the community, when they talk about the comorbidity, they always jump in the TB and diabetes or TB and HIV. If you look at the burden, what is the burden? Smoker. I think smoking is one of the key factors. Even I haven't seen in your slide, even I haven't seen in Dr. Sachideva's slide. Of course, you are doing great job, but we need to also look at the, or any of the presenter, we need to really look at a comprehensive approach that we need to offer to our people. I think that is something really great thing we need to do. So that's to conclude this. Very simple thing that we can do is the ABC. The first step, the TB control program has to include or integrate ABC, that is smoking cessation intervention within the regular TB control program. It can be done in 1 minute. It doesn't require any additional resources. It doesn't require any additional money. Resources mean money. What it requires local, our DOT providers commitments and one line, one sentence in a TB control policies. That's all. So I think that's my, I would like to conclude this year. Just last one is the, legislation. I think what is happening now is in many countries, we have a technical guidelines, we have many things. We don't have in many countries like TB law, TB legislation. So it's I think one of the tools that we really need to address the TB control program, we need to have the national legislation that needs to be defined, a clear role of all the stakeholders, the different level of governments, and their role, their responsibilities should be clearly defined, that including the private sector. I think that's really important. We need to also keep in mind legislation should be one of the key pillars of the TB illness. Yeah, with this, I would like to conclude there. Thanks.
I think they have control in their slides, in their presentation, because we had you here for that.
No, I'm just saying. Even I spoke with the guy, the same thing, 18 months and all the smoking. So I complained that.
I now invite Elizabeth Aru, Head Program Development, Humana People to People India, who are doing wonderful work on the ground.
Good morning to all. And since we have approximately 1 minute, I will read the headline and I'll show you the pictures. See, the headline of this presentation is Reaching the Homeless and Migrant People with TB Services, Making a Difference Where It is Needed the Most. And we always learn a lot from Dr. Saxdeva. And he has come forward and also taught us a lot about the new tools and the importance of using TrueNet for testing, which we are not doing enough in India. In the last year in Delhi itself, we reached out to more than 1.5 lakh people, 150,000, and we found more than 1,500 people TB. And not even 13% of them were tested with NET. So we know that we have missed some of the cases. Now we have also learned one more time from Dr. Saxdeva that we should also test the people who don't have symptoms, because in the slums where we have many homeless people, and when I say homeless, and we have also added migrants, it's because it's not only people who are living at the roadsides or in shelters, but some are living 10 people together in a room, and then that is 2 shifts because they are migrant workers. So that is a very stressed, very close setting. And there we, of course, find people too late. We should have found them long before. Nevertheless, we have developed some good practices to reach out, and also understood that we should be there early in the morning, late in the evening, have a very friendly and welcoming approach, being able to break the ice with people who are in different circumstances. And it is possible if we are there, because as you also said, Dr. Saxdeva, we have the tools, but somebody needs to bring them out to where the people they are. So we are there for that, and thank you for the beautiful pictures from the Philippines. Now I will show you 2 not so beautiful pictures from India, but I don't know how to move this. How should I move these slides? Yeah. Yeah. This is see, this is one of our good examples of collaboration with private sector. We have many companies and also many private people who have been supported with the nutrition support. We have organized street plays with TB awareness, and we are also going from door to door among the people, among the people who don't have any doors. So it is possible to reach out to people with some good approaches and also to be there in the same communities for a good long time. So with this, I would say thank you for the attention and the opportunity, and let us keep on the good work.
Thank you very much. For Amit Singh Hussain from TB People India, from the community, voice of the community.
Thank you so much. I think I only have to say hi and go back because everybody has said everything. So thank you because everybody has added everything that I was prepared. So I will say as a community, as a representative for TB People India, I have two things to add. That India has the biggest role of TB people in the world, and to meet this target, the government of India has launched several programs. They have introduced the TB program as a flagship program, and TB in India, and then the ma'am has told about the TB challenges in India. Government has also providing the direct beneficiaries CBT scheme, distribution scheme, adoption to engage society people, to engage communities, to engage the people who are on ground and taking the support of community and other peoples to end that TB. I want to say that we have, as India, we have done not much, not less. We are still have to do. We have to do in terms of quality service. We have to do a lot in terms of quality accessibility. We have to do a lot in terms of regime that we have to improve. We have to do a lot in terms of technology because, as sir was saying, that sir and ma'am has also mentioned that we are using the oldest technology. There are several cases of people who are not identified. So there is still a need where we can invest more. And as a community person, because I have seen my sister also who has suffered from the severe extrapulmonary TB infection, where have seen her body how changed, how everything has changed in her body. She was a chubby girl, having a good fat and everything.
Sorry, there will be another session here. We have to also respect your
Just
time.
30 seconds, yeah. So I have seen that, and then how it drastically changed that I have seen in my sister. So what as a committee I want to add here, we need more commitment for the elimination and TB, and we need more investment to TB and more investment in community also. Thank you so much.
Thank you very much. Have to move out because respecting.
The presenters, maybe just a picture, just for you.
We have your session.
You will see what people are.
Yeah.